everybody. I just wanted to introduce a new study that is going to be started in the next few weeks. And it's basically looking at seizures after congenital heart surgery and clinical recognition versus EEG diagnosis. And this is important. I really want to get your guys' input on this because your involvement in this study is actually pretty critical. So basically, the little background of why we're doing this is that there's a big interest in neurodevelopmental outcomes in our babies, and one of the implications is that post-op seizures are suggestive of brain injury, but a lot of times these are subclinical in nature, and right now our clinical status quo is to wait until we actually see clinical seizures before we actually think about it. But at other centers, routine EEG monitoring is used in all of their neonates, and so we're going to do a pilot study looking at the effectiveness of that and comparing it to our own clinical recognition and ultimately trying to figure out who would best be served in using routine EEG monitoring. So this will be babies less than 30 days. The EEG monitoring will be for 24 hours. If it's abnormal, then it will continue for longer than that, but it won't be part of our study. We are going to rely on the bedside nurses to let us know when the best time to come for the EEG technician to come. We really wanted to have the leads placed in the OR, but anesthesia put up a huge fight for that. So I understand that there's a huge, like getting the patient tucked in is obviously an important part, and we don't want the study to get in the way of that at all. So just letting you guys, giving us a time limit of when to come and have the EEG leads placed. And the biggest part that I would want you to kind of give me your say on is how to document this. So there's a sheet here that just kind of highlights the parameters that we're looking at, and I just wanted your input on whether or not it would be better to use this written document versus using MyChart and having us extrapolate this data from the MyChart. So we are looking at vital signs at the onset and your description of them and giving you specific seizure movements so that it's a little bit uniform.
So we're really only charting if there is seizure activity on it.
Exactly. And just kind of using some of the same words. So on the second page, it gives you descriptions of what you would, like what you think the clinical seizure looks like, just to have it be a little more consistent and uniform. Our neurologist does ask that if you suspect that your patient is having a seizure, to push the button on the monitor so that she can see exactly what you see. And like the one nice thing about the paper is that you can check the box if you don't really think any seizures happen during your shift. But your input on this would be much appreciated. So if you feel like this paper would be too much work for you because you have to document it in MyChart anyway, just let me know that, and we can extrapolate the data. What are your thoughts?
I kind of feel like if we're only charting if there's seizures, then I don't think it's a big deal to have paper if that's easier.
Okay.
But that's just me. So I can remind everybody to chart on it if it's at your
It would kind of be a
bedside.
visual reminder that your patient is in the study.
If you're pushing the button, if you have this right by it, then you can hit it.
Okay, great. So then we'll plan on using the paper and having you document it there. And then we'll just pick up the papers and we'll have a stack at the bedside for each nursing shift to have this in 24 hours. If your patient gets neuromuscular blockade at all, then the clinical portion is over. Like they'll continue to look at the EEG monitor data, but obviously you can't detect the clinical seizure if they're blocked. So.
Does that say that in here somewhere, Melissa?
No, it doesn't, and I can put that in there.
Yes, if you would please,
For sure. Okay.
so they know that.
So that's really it. It's
That's it?
that's it.
That's it.
So is there consensus? I mean, you guys all agree that documenting, having the paper form there to prompt you to document it would be the best approach. We still will have to put it in MyChart though.
Anything I can do to avoid my chart?
I know, Tiff. I know. We still have to put it in MyChart though if there's a seizure. It's
Yeah.
sitting right there. And like Melissa said, the nice piece is you can actually say that no seizures occurred. So it prompts you, and then they'll
Right,
get
that's
that
helpful to us
feedback.
when
It's
we
not
do
like they were missed or something. And you know, remember, you can, if you miss the vital signs at the time that the seizure occurred, you can go back and find them in MyChart, right? So then you can still document them. There was a question about the temperature.
Yes.
When we looked at it, we thought, we don't have to can it be within a certain time frame that a temperature was taken? Not that we see the seizure happening and we're gonna rush to take a temperature.
Right, no, I think
Right.
within the hour, like most, I
Okay.
guess we could clarify this and just be like most recent temperature prior to onset, like within that hour.
Within an hour?
Yeah.
Does that sound reasonable to everybody? Temperature
So
within
then
the
it's
hour?
like it's your own vital that you're getting anyway, so.
Okay. And these descriptors are the ones you would like us to use?
Correct. So these are pretty uniform ways that neurology describes their seizures in their studies that they've done previously.
Okay. The practice of pushing the button is nothing new.
Right.
Right, that's
We
just
do that
same
now,
level, correct.
so that would be the same. And will we get feedback on this research study at some point?
You will. So you will not know if there are clinical or subclinical seizures happening on the EEG. But the treatment team will be treating the seizures at their discretion. So the doctors will be notified if there are abnormalities, and it will be up to neurology and the attending physician as to whether or not they want to treat them. Our suspicion is that they will likely be treated sooner. That's kind of the whole point of the study, is to see if detection of these subclinical seizures and treating them sooner rather than waiting until they become clinical actually ultimately improve neurodevelopment outcome. That's our big long-term question. So your suspicions will be confirmed when phenobarbital shows up on your mark, but no one will be calling you to say, yeah, what you saw was a seizure. So
Okay.
the neurologist is actually going to look at this every 12 hours, or twice during the study to see and what's going on.
So all of our infants are gonna come back then?
Angie, why don't you ask that louder? Go ahead.
All of the babies are gonna come?
Only those that are being consented to do so.
Oh, okay,
And are
So we
less
have-
than 30 days.
No, less than 30 days,
Okay.
but we'll be approaching all of them.
okay.
Who would be doing the consent?
Me, and effective July 1, Courtney. So Courtney will be a
Hi,
second-year fellow
Courtney.
with you in July,
Okay.
and this is going to become her study.
Is there any
Okay.
kind of defect that would, like heart defect that would take them out of the study?
No, so we're looking at both single and two ventricle repairs.
Okay.
Okay.
Yep.
And it's just the first 24 hours post-op.
Correct.
Okay.
So if there are true seizure abnormalities, then it may continue longer than that from a clinical standpoint. And we'll continue to collect the data beyond that. But after the 24 hours, it becomes for clinical reasons and not our study. So.
And I'm assuming we have enough EEG machines to accommodate the research
You know,
study?
I was surprised. We only have 12 EEG machines in this entire hospital. Because when I started this all started out as a QI project, actually. I'm like, oh, EEG is for everybody. The CHOP is doing it. But it wasn't really that simple. And so obviously clinical priority takes precedence over the study. But
Okay.
I mean, the chances of having to use all 12, I mean, we don't, especially because we're only
Yeah.
doing it for 24 hours,
Yeah.
so that frees it up pretty quickly
Yeah.
again.
Yeah. So I guess we'll know that the EEG study is in process because the EEG machine will be sitting there. So we don't need any sign for above the head, right?
Well, this is pretty much a sign
Yeah.
on that.
Here,
So-
Tiffany, do that again. What will be our clue? Oh. So do you think we need anything more than what Melissa has already prepared at the bedside? Just maybe somewhere, put a reminder on there that we, as soon as possible, who are we gonna call to get the EEG placed? Do we just,
no, we will be responsible. I'll be checking in with them. Courtney will be checking in. We'll be aware of who our post-op babies are for the day.
okay,
So it'll just be us checking in with the bedside nurse
Okay.
and trying to figure out a good time period for the EEG tech to come in. So
Okay.
that'll just be us touching base with all of you.
So
So
they're
we-
most likely going to come back from the OR with an order for a continuous EEG. Is that going to be part of their post-op order
Yes.
set?
We'll put it in. Courtney and I will.
Okay.
But really, like, we don't want this to get in your way, and I know that there's flow post-operatively, that you're not going to have an EEG tech showing up the second your Norwood rolls back in. We really want the baby to be tucked in and at a good spot for you as nursing, so.
yeah, that'll be helpful if you guys come to the bedside, because then that'll also be just a touch base with the nurse and
Right.
remember what we're
And that's
doing,
when we'll
kind
drop
of
off these
thing.
papers and for the first few, touching base with what we need to do. And if we do a few of these and the paper is tedious and slows you down from taking care of the patients, then we can adjust and go to my chart if that's better. So
Okay.
feedback is welcome.
Okay, and who will collect them the next day? You guys will make
I will
rounds
coordinate
and
that,
you'll come?
yeah.
Okay, so we don't have to worry about delivering them anywhere or
No,
doing
Just
anything with
leaving them at your
them?
bedside in the stack and then we'll come get them.
Okay. Any other questions? Okay, we should get Courtney on video so everybody knows who Courtney is. There's Melissa's counterpart, Courtney. Hi, Courtney. Okay, all right. Well, that was 10 minutes, short and sweet. Thank you.
Thank you.